Good evening, everyone. So, my next video on the topic, which I'm going to discuss with you today, is on the topic drug use in renal disease. That is how we have to use the drug in renal dysfunction. I will discuss this topic with you in this video. And before I start my video, I want to request you if you like this video and if you understand this video and if you learn from this video, kindly subscribe to my YouTube channel, that is Dr. Nitika Pharmacology Discussion. And now I'm going to start the topic renal drug use in renal disease. Now, kidney is an important organ in regulating body fluids, electrolyte balance, removal of metabolic waste, and drug excretion from the body. Means it regulates the body fluid, it maintains the electrolyte balance, kidney, and it removes the metabolic waste and it excretes drug from the body. Impairment or degeneration of kidney function affects the pharmacokinetics of the drug. Is whenever there is impairment or degeneration of kidney function takes place, it affects the pharmacokinetics as well as the pharmacodynamics of the drug. Some of the most common causes of kidney failure include. Now, what are the most common causes of kidney failure? They are any disease of the kidney like pyelonephritis or glomerulonephritis, any hypertension or diabetes mellitus, any injury to the kidney or drug intoxication, any drug poisoning has occurred. It can lead to kidney failure. Any injury to the kidney can lead to kidney failure. Now, types of renal failure, which is divided into two types, such as acute renal failure and chronic renal failure. Acute renal failure, it develops suddenly from a within a matter of hours to days. Means it develops within a matter of hours to days. And in this, there is increased accumulation or increased concentration of urea and other toxins in the body and can be divided into three types such as pre-renal, renal and post-renal acute renal failure. Pre-renal is when there is decreased blood flow to the kidney. Renal is when there is disease of the kidney like pyelonephritis or glomerulonephritis. Post-renal is when there is obstruction to the urine flow from the kidney. That can lead to acute renal failure. Management can be by the drugs which affect the primary etiology or supportive functions. Supportive functions like dialysis, which is a used for the supportive renal functions such as dialysis and any drugs to treat the cause of etiology. Now, chronic renal failure has been divided as kidney damage for 3 or 4 months. Means it is the kidney damage for a period of 3 or 4 more months. And there is structural and functional abnormalities of the kidney, and there's also reduced GFR. Pathological abnormalities can occur, as well as the markers of kidney damage can detect the presence of the chronic renal failure, and there can be abnormalities in the composition of blood and urine, and GFR can be less than 60 milliliter per minute per 1.73 meters square for 3 months or more with or without kidney damage. Means there can be structural abnormalities, any functional abnormalities, any pathological abnormalities. GFR can be reduced till 60 milliliter per minute, and there can be uh, kidney damage can occur. It occurs for a period of 3 months or more. And end-stage renal disease is characterized by a stage of compromised renal functions. Means there is compromised renal functions. End-stage renal diseases when there is compromised renal functions presenting as uremic syndrome. Uremic syndrome is when there is increase in the urea levels in the body, and this compromised means decreased renal functions can occur that can lead to end-stage renal disease. Now, this is the cause of renal failure. These can be pyelonephritis, hypertension, diabetes mellitus, hypovolemia, nephrologists, and various drugs can lead to kidney failure. Drug elimination can occur by two methods, such as glomerular filtration and active tubular secretion. And clinical diagnostic lab tests for renal diseases, blood urea nitrogen. And normal blood urea nitrogen is 10 to 20 milligram per deciliter. Now, drug toxicity can occur when there is alteration, means there is decrease in the renal blood flow, mostly by non-steroidal anti-inflammatory drugs. Prostaglandin metabolism is decreased, means production of prostaglandin reduces. So, glomerular perfusion can be reduced. Alteration in renal blood flow. Direct tubular toxicity like nephrotoxicity by these aminoglycosides like streptomycin and cisplatin. Glomerulonephritis can occur by mold and penicillamine. Now, pharmacokinetic considerations in patients with renal failure. There can be decrease in the gastric pH. Why? Because there's increased level of urea, and urea gets converted to ammonia in the stomach, which can lead to decrease in the gastric pH, and which can modify the absorption of many drugs. And all gastrointestinal hormones like gastrin levels can increase, which is due to decreased breakdown of gastrin, which can lead to decrease in pH, motility, GI motility is reduced, blood flow is reduced, which can reduce the absorption of various drugs. And there can also be increased incidence of mucosal ischemia, and which will affect the drug absorption from gastric mucosa, and there can be GI bleeding in these patients. When there is incidence of mucosal ischemia that can lead to reduced absorption from gastric mucosa, and GI bleeding can occur in patients of chronic renal failure. Apparent volume of distribution of many drugs can be changed. Why? By changing the fluid balance, circulating proteins, levels of endogenous molecules, and toxins, altered vascular permeability, and drug protein binding. Means the apparent volume of distribution of various drugs can change. Why? Because they can be changed fluid balance, circulating proteins can be changed, level of endogenous molecules and toxins can be changed, and there can be vascular permeability can be reduced, or drug protein binding. It can increase or decrease. Example, warfarin and valproates, they have high plasmaprotein binding. Vancomycin have low volume of distribution. Changes in total body water and third space collections modify the concentration of drug in central compartment. Means total body water can be reduced in the third space collections also, and that can lead to increased concentration of drug in central compartment. The drug elimination is there can be reduced metabolism and excretion of the drugs in the patients with renal failure, and these changes will maintain the dose modifications for various agents. Means for various drugs, the metabolism and excretion is reduced, so we have to give the drugs in low doses, otherwise toxic reactions can occur. Now, there can be effect of uremia on hepatic enzymes, which can lead to decreased metabolism, decreased hepatic elimination, and that will require dose modifications. We have to give the drug in low dose as well as reduced frequency. We have to give the drug. The drug transporters in patients with chronic renal failure, tubular transporters, there are two types, ATP binding cassettes and solute carriers. And reduction in expression of cytochrome 1A, organic anion transporters, P-glycoprotein. Now, there was reduction in expression of these transporters like cytochrome P1A2 and organic anion transporters, P-glycoproteins. And this will lead to reduced expression of transporters. So there will be more accumulation of the drugs in the body. Interrenal accumulation of the drugs will take place, and they will reduce the clearance of the drugs because transporters will not pump the drug, or will not transport the drug from the body inside the lumen and the loop of Henle. And so there will be increased accumulation of drug in the kidneys, and clearance will be reduced. And there can be decreased metabolism of the drugs due to changes induced in hepatic microsomal enzyme necessitating drug dose modifications. I've already told you hepatic enzymes, uremia will occur on hepatic enzymes, and that will lead to decreased metabolism. And so this will require the dose modifications. Phase 1 and phase 2 metabolic reactions are slow. This metabolism is slow. So that can lead to, even for a bit of increase in dose, if we give the drug in high dose, that can lead to adverse drug reactions. If the dose modification is not done, means if the drug is not given in low dose, or we have to reduce the frequency also of the drug. If the drug is not given in low dose, then as the metabolism is reduced, phase 1, phase 2 metabolic reactions are reduced, excretion is reduced, clearance is reduced, that can lead to increased incidence of the adverse drug reactions. Pharmacodynamic issues in patients with chronic renal failure is there can be increased incidence of nausea and vomiting, which can lead to decrease in compliance. Compliance is how much the patient is abiding the instructions of the physician to take the drug regularly. And as the patient is suffering from nausea and vomiting, so that can lead to decreased compliance, and the absorption can also be impaired from the GIT. There can be altered responsiveness to the CNS activations, psychoactive agents like amphetamines, methylphenidate, dexamphetamine, they can be also responsible to these drugs. And this electrolytemia means there is electrolyte imbalance, which will lead to altered responsiveness to drugs like digoxin. Now, how we have to approach the patient with the renal failure is we will take the history, which will show that there is reduced urine flow and edema can occur in the patient, and how we have to measure the renal failure, how we have to measure the renal function. The rate of elimination of drugs is exceeded by kidney's proportion to glomerular filtration rate. Is how much of the drug is eliminated from the body. It will depend upon the glomerular filtration rate. This rate of elimination depends upon the glomerular filtration rate. If GFR is reduced, elimination will be reduced. If GFR is increased, elimination will be increased. And creatinine clearance determines the renal function. Creatinine clearance. Cockcroft and Gold equation is useful for this purpose. Like creatinine clearance given in liter per minute is given by the formula 140 minus age into body weight in kgs, age in years into body weight in kg upon 72 into serum creatinine milligram per deciliter. What is the serum creatinine of the person? 72 multiplied serum creatinine, that will lead to creatinine clearance. Pediatric creatinine clearance, such as of the infants, it is 0.48 into height in centimeter into body surface area upon serum creatinine into 1.73. And 1 to 18 years creatinine clearance is 0.55 into height in centimeter into body surface area upon serum creatinine into 1.73. This is for the children. Now, dose calculations in renal dysfunction. Kidney is the main organ of elimination, excretion of majority of the drugs from kidney, from body, which is the main organ of elimination. That is of metabolism and excretion of majority of the drugs. And any kidney disease affecting elimination of excreted products and drugs will require reduction in doses of drugs which will be related to creatinine clearance. With creatinine clearance, it depends. It is the more main basic parameter or endpoint which we have to know in the patient of renal disease. That is, the reduction in doses will be related to creatinine clearance. And as the elimination of the excreted products will be reduced, so we have to reduce the dose of the drugs also, which will be related to creatinine clearance. So this is again changes in elimination in elderly. Decline in glomerular filtration rate in tubular excretion in elderly is there. So Cockcroft formula is same. How we have to estimate the creatinine clearance? It is given by 140 minus age in years into weight in kg upon 72 into serum creatinine. For the males, this is the formula, and for the females, that is, if the patient is a female, we have to multiply by 0.85 if patient is female. So next is dose adjustments in renal dysfunction. Now, how we have to do the dose adjustments in renal dysfunction? Loading dose is not changed, except in edema, as depends upon the apparent volume of distribution. But maintenance dose, it depends upon the clearance, and given by the formula, maintenance dose is target concentration into clearance on IV administration. So we have to reduce the maintenance dose. So in renal dysfunction, clearance is reduced and maintenance dose is also reduced. Now, how we have to notice that just a daily dose of the drug, it is by the dose for normal renal function multiplied by patient's creatinine clearance over normal creatinine clearance. And normal creatinine clearance is given by 120 milliliter per minute, and 70% reduction, 75% reduction shows renal dysfunction requiring dose reduction. Now, just a daily dose, it can be given by the formula dose for normal renal function multiply the patient's creatinine clearance upon normal creatinine clearance, and normal creatinine clearance is 120 milliliter per minute. And this patient's creatinine clearance will be calculated from the previous formula, and 75% reduction shows renal dysfunction requiring dose reduction. Now, this is the dose reduction guidelines. The creatinine clearance 70 milliliter per minute. Dose is reduced to 70%. Creatinine clearance 50 milliliter per minute. Dose is reduced to 50%. Creatinine clearance is 30 milliliter per minute. Dose is reduced to 30%. 10 milliliter per minute, dose is reduced to 20%. Percentage of dose reduction in renal dysfunction is equal to percentage of creatinine clearance reductions. How much is the percentage of the creatinine clearance reduction? That will be equal to percentage of dose reduction in the renal dysfunction. And in renal dysfunction, IV drugs getting eliminated from other routes, that is not from the kidney, but from milk, from bile, from saliva, from skin, they are preferred. Drugs which are eliminated from the lungs, they are preferred if possible. Now, general precautions in renal dysfunction. Drugs are to be avoided wherever possible. Means we have to avoid the drugs wherever possible. And drugs which excrete unchanged, like atenolol, aminoglycoside, digoxin, phenobarbital, they are to be avoided. Nephrotoxic drugs like aminoglycosides, potassium-sparing diuretics, which cause hyperkalemia and cardiac depression, pethidine, tetracyclines except doxycycline, nitrofurantoin, amphotericin B, cyclosporin, vancomycin, hydrazine, sulfonamide, heavy metals. These are the nephrotoxic drugs and these are to be avoided. Antibiotics, they require dose reduction in renal dysfunction. They are cephalexin, ethambutol, acyclovir, cotrimoxazole, carbapenicillin, ciprofloxamine, norfloxacin, ciprofloxacin, metronidazole. These are the antibiotics which require dose reduction. In renal failure, we use a loop diuretics instead of thiazide diuretics. So in renal failure, for the congestive heart failure disease, we have to use the furosemide as thiazide, they reduce the GFR. Highly protein-bound drugs like phenytoin, trimethyl are avoided, and drugs like uricosurics, that is, which increase the uric acid excretion, like allopurinol, propanil, sulfabuxostat, and cholecalciferol, which is vitamin D. These are ineffective and avoided. While in anemia due to chronic renal failure, we have to give the Imaginax along with erythropoietin. This Imaginax like parasols, parasulfate, parasgluconate, tablets, fumarate, they are given along with and vitamin B12, they're given along with erythropoietin in anemia due to chronic renal failure. And there can be poor excretion of urinary antiseptics, which can lead to systemic toxicity, and hence the urinary antiseptics are also avoided. Therapeutic drug monitoring is to be done wherever necessary. Therapeutic drug monitoring is done in the drugs which have a narrow safety margin, narrow therapeutic index, and therapeutic window. And therapeutic drug monitoring is the phenomenon in which we know the dose levels of the drug, plasma levels of the drug in the body. And if the drug levels are below the minimum effective concentration, that can lead to therapeutic failure. And if they are above the minimum toxic concentration, maximum toxic concentration, so above that dose, that can lead to therapeutic adverse drug reactions, minimum with toxic concentration, and if the above that, that can lead to, if the dose levels are above that, that can lead to adverse drug reactions. Means the drug should lie in between the therapeutic window. So prophylaxis of the drug-induced renal failure, amphotericin B, we have to adjust the dose, hydrate with normal saline infusion, use liposomal formulation. Amphotericin B is the antifungal drug. We have to give a dose in low quantity, or we can hydrate with normal saline, and we can use the liposomal formulations. ACE inhibitors, they are avoided in bilateral renal artery stenosis. Acyclovir, we have to avoid the bolus. This bolus injection of acyclovir is not given. We have to adjust the dose. Thank you. That's all for drugs for drug use in renal disease. I hope you understood my lecture, and if you like this lecture and if it's useful to you, I request you to kindly subscribe to my YouTube channel. This is Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be healthy, be blessed. Stay safe. Work smart, work hard. Thank you. Happy learning.